Welcome to podcast 4.
I'm Fran,
And I'm Minnie.
and as usual, we'd really appreciate your feedback, so please do that via the forum.
Today's topic is community-acquired pneumonia in adults. And our tip for our podcast is always count the respiratory rate of your patient. And in an adult, this would normally be between 12 and 20.
So, to discuss a community-acquired pneumonia, we thought we'd illustrate it by discussing a case. So, a 66-year-old lady comes to see you with a 4-day history of cough. So, initially, this was a dry cough, but now she's producing a brown-coloured sputum. She feels shivery, generally unwell, with myalgia, so that's muscle pains, and a fever. She thought it was just a cold, but barely slept last night with all this coughing, doctor. And it's left her with a right-sided chest pain, particularly when she's breathing in and out. And that's a pleuritic pain, which we discussed in previous podcasts.
That's right.
So she says she doesn't feel short of breath, but is breathing a little bit quicker than normal. And she has no leg swelling and is not having to sleep propped up on pillows.
Great.
So we ask her a bit about her medical history, and she tells us that she has high blood pressure and is on medicines for that, and she's a smoker.
That's really a really succinct case. Thanks, Fran. So on examination, as you would obviously go on to, we find that she has a fever of 38.5 degrees centigrade. We've taken her blood pressure, and this is 128/76. Her heart rate is 102, which is a bit fast. Her respiratory rate is 30. And as we've already discussed, this is a bit fast again for someone of her age. And her oxygen saturations are 94%. Now, I appreciate that you don't all have oxygen saturation monitors in your clinics. So it's worth reminding ourselves that clinical central cyanosis will be seen at about oxygen saturations of about 85%. So quite a way below the saturations that we were seeing on this patient. So she's okay from that point of view. Continuing the examination, she has dullness to percussion over the lower left lung, and auscultation of this area shows decreased breath sounds with no crackles or wheeze.
Fantastic. Yeah, so that's a very thorough examination very quickly, which we need to be doing in this primary care setting. We don't have time to examine a whole patient, so just looking at her respiratory system is the important thing to do. So there's a whole long list of the different diagnoses that this patient could have, but the things that would be initially on my list would be, is this a pneumonia? Could she have fluid there, a pleural effusion? Could she have COPD? So could she have chronic airways disease from her smoking, which hasn't yet been diagnosed, and then this is an exacerbation of it? Or is this acute bronchitis? Or indeed, is this fluid on her chest from heart failure?
Okay, so probably, Fran, with you mentioning that as a part of the differential, we should also examine her cardiovascular system, which we haven't put the findings of, but in this case, they would have been normal. So her heart sounds and no edema anywhere.
Fantastic. Yep, thanks, Minnie. That's really true.
Okay, so we've had her history and taken and done the examination. What should we do next? Well, the clinical diagnosis here is of a community-acquired pneumonia. But if you're unsure, you can do other tests. So you could do a full blood count, a CRP, which shows the level of inflammation going on, which we would do certainly in the UK, and also a chest X-ray if it's available to you.
Yeah, so I think that's really helpful. But so in my practice, if I was confident of the diagnosis, I wouldn't necessarily do any of these. I would just start treatment, and it would only be if they were getting worse or they weren't getting better with the treatment that I would then go on to do those. And you could also do sputum for microbiology. But again, I don't do that routinely in the UK. But obviously in Zambia with TB, you may well want to.
Okay, that's really useful, actually. Now we'll go on to just discuss community-acquired pneumonia briefly. So it's a common disease, and it's a pneumonia that's acquired outside hospital or outside healthcare facilities. and it tends to be a clinical diagnosis, as we've mentioned, based on the group of signs and symptoms that we've seen in our case here. So fever over 35 degrees centigrade, or if you're using Fahrenheit, over 100 degrees Fahrenheit.
Sorry, was that 35 or 38?
Oh, I said 35. I meant 38 degrees. Thank you, Fran. Good job you're listening.
Yeah.
So fever, cough. Are they producing any sputum with the cough? Chest pain, shortness of breath, and any other signs of respiratory problems?
Yeah, so hearing things when you auscultate the patient is an important thing. So I'm mindful of that, but also I'm mindful that in older patients, sometimes they don't present like this, Minnie. So sometimes they don't have a fever. Sometimes they're just confused and they don't feel quite right. And you have to be very aware of that you have to be suspicious that there might be a pneumonia there, and examine an older confused patient very carefully to look for signs of an infection.
So in those cases, Fran, that your clinical signs are really crucial to you finding the diagnosis in that detective way that we've discussed in our other podcasts.
Yeah, I think that's really true. And in fact, I've even seen younger patients where I've been convinced they've had a pneumonia, but I've listened to their chest and I've not heard anything. And then actually when I've done a chest x-ray, it has confirmed that there's been a pneumonia there. So if somebody has the story, the history for all those things that you've mentioned that come with a pneumonia, just think, is it this, even if I'm not hearing crackles in the chest? Yeah.
Mm-hmm. Okay.
And the thing to be mindful of is that it often comes as a sort of super added infection. So maybe someone starts with an initial viral illness like an upper airway, a mild cough, and then they get a super added infection which turns into a pneumonia.
Okay. Are there what are the common causes then, Fran, for community acquired pneumonias?
So pneumococcal is the most common one, and in the UK now, certainly with our elderly patients, we give them a pneumococcal vaccine to prevent this. And following on from that, it would be Haemophilus influenzae, Staph aureus, and then atypical ones. So you'd see more of this, obviously, in Zambia, which would be tuberculosis or mycoplasma, and of course viral pneumonias are very common as well.
Yes, and those obviously are not going to respond to antibiotic treatment.
No, which can sometimes make them hard to treat.
Indeed. Okay, so we need to move on now to thinking about how we're going to treat our patient.
Yeah, so there's this brilliant scoring system called a CRB65, and that helps us quickly decide where the safest place to treat a patient is. So C stands for confusion. Is your patient confused or not? R is their respiratory rate. So again, this reinforces why it's really important to count it. So they get 1 point for being confused, 1 point if their respiratory rate is 30 breaths per minute or more. Mm-hmm. The B is for their blood pressure. So if their systolic is 90 or less and their diastolic is 60 or less, that gives you 1 point. And if they're over 65 years old, that also gives you 1 point.
Okay, so we've created a score. We need to know what that means, don't we, Fran?
So with this patient, she'd score 1 for being over 65 because she was 66.
Yeah.
Her blood pressure wasn't that low, so she doesn't get a score for that. Her respiratory rate was 30, so she'd get 1 for that. And in fact, we didn't comment on it, but she wasn't confused.
No, so she's able to give us a good history, so one assumes she's not confused.
But she got a scoring of 2. So what did the scores mean, Minnie?
Okay, so a score of 0 shows that you're at low risk of death. Is actually how this score is calculated. And normally these patients won't require hospitalisation, won't need to go into hospital. You can treat them safely at home. If they have a score between 1 and 2, then this means it's a bit more of a severe infection, that they have an increased risk of death. So at this point, you need to consider whether you need to refer them to hospital, whether they need to be treated in that environment. Mm-hmm. And a score of 3, they're severely ill and at high risk. So urgent hospital admission is required usually in these patients. But it is important always to take into account other risk factors. So even if you've got a patient with a score of 1 and they've got comorbidity, so other illnesses like COPD, or have other chronic chest problems, you may want to admit them sooner than you would someone with no other risk factors. Or and also you need to look at the patient's social circumstances and their wishes. So as we've discussed, Fran, in the UK, if you have an elderly person living on their own who isn't really able to take their medication, you might admit them with a lower score than someone who has got good care at home around them and can look after them.
Yeah, fantastic. And I think what's happening much more in the UK now, and I think a lot of the clinical officers do this, is that so we have something called ambulatory care. So somebody with a score of 1 or 2 would go to a healthcare facility, have IV antibiotics, then go home to sleep, and then come in the next day for further IVs. So they wouldn't be admitted to a hospital, but they would be getting that sort of step up level of care from just having an oral antibiotic.
And obviously being reviewed on a regular basis, which is really useful.
Yeah. So, I mean, the guidance say within 48 hours, but obviously sooner if the person's getting more poorly.
Mm-hmm.
Right, so treatment-wise, so if we have a patient with a score of 0, then this is low severity, and we can treat them with oral antibiotics. And in the UK, the first-line antibiotic is amoxicillin with a dose of 500 milligrams 3 times a day for 5 days. Now, obviously, some patients are allergic, or you may not have amoxicillin, so then you could use either doxycycline or erythromycin as an alternative. And again, with the 5 days, you may need to do a longer course if the patient isn't improving as quickly as expected.
Mm-hmm. Okay, so moving on to someone with a moderately severe pneumonia, then you'd probably treat them, or the advice is to treat them for 7 to 10 days, and actually to consider dual therapy, so more than one antibiotic, 2 antibiotics. So with your amoxicillin, you'd add in erythromycin. And in severe, high severity cases, you would actually give a cephalosporin and erythromycin and not the amoxicillin. So again, dual therapy, but the different antibiotics. So it's worth keeping those in mind and using, obviously, what you have available to you in your setting.
Fantastic. And the advice is not to routinely give steroids unless the patient has another condition for which they're required. So, for example, if they had asthma as well and were very wheezy, then you would need to give steroids. But for a straightforward community-acquired pneumonia, you wouldn't do. And then the final thing is that if somebody has a very high CRB score, and it's severe and life-threatening, then the advice is to give 1.2 grams of benzyl penicillin intravenously, or 1 gram orally, if that's not possible, before you transfer them to hospital.
Okay, and just one final point I'd like to make, Fran, is, this lady had right-sided chest pain, and we must keep in mind that pain is something that we also need to treat. So if someone presents you with the pleuritic chest pain, give them some simple analgesia such as paracetamol, if you have it available, or aspirin, I guess, would be something that, certainly looking at the cases, a lot of patients seem to be given as analgesia in the clinics.
Yeah, I think that's really vital, because it's really important that she's pain-free enough that she can keep coughing and keep expectorating.
Indeed.
And then just to remember that if the patient isn't getting any better, then to consider other diagnoses. So maybe this isn't a pneumonia, maybe it's one of the other conditions we talked about. Could it be a malignancy? Could there be an underlying lung cancer with an infection around it? Or could it be TB, obviously? And then finally, I just wanted to say as well that it takes patients a very long time to recover from a pneumonia. So the most recent guidance I read suggested that even up to 3 months, it takes 3 months to recover. So all that time they will be getting better, but the cough won't get better as soon as the antibiotics have stopped. The cough takes a while to get better. The shortness of breath will take a while to get better. The feeling of fatigue and aching. So, reassure the patients that it has been a serious illness and it will take time for them to get back to normal.
And they won't necessarily need more antibiotics in that time.
Exactly. Yeah.
Thank you, Fran. So these guidelines that we've given you here are just the current guidelines, but always trust your clinical judgment, so that if you have a patient who you think is extremely unwell and yet has a low CRB score, trust your instinct and treat them for the severity that you're seeing in front of you.
Absolutely. So guidance are there to help us. They're not there to be followed rigidly. I couldn't agree more, Minnie.
Okay, well, thank you for listening to this podcast. We hope you've enjoyed it. It's goodbye.
Thank you very much. And it's goodbye from me. Bye.